Welcome, everybody. Hello, my name is Renee Miller. I go by my pronouns she, her, and I'm the Associate Director at the Oregon Bioscience Incubator. And welcome to this Lunch and Learn on examining digital health through an equity lens. While we get settled, here are some housekeeping items. So that we can hear our presentation, I'm asking you to please stay muted, but I really encourage you to introduce yourself in the chat. And if you'd like to put your LinkedIn information in there so that folks can connect, please do so. And you can also use the chat to ask questions of the presenters, which will be taken at the end. My LinkedIn is in the chat, and so please feel free to connect with me. So with that, let's get started. OTRADI would like to acknowledge the land we're all on, wherever we may be. OTRADI conducts business throughout Portland and beyond, and is making an effort to acknowledge the history of the area and work toward decolonization of the bioscience industry. Portland rests on traditional village sites of the Multnomah, Cathlamet, Clackamas, Chinook, Tualatin, Kalapuya, Molalla, and many other tribes who have made their homes along the Columbia River. So please join us in acknowledging the land we are all on throughout Portland and beyond. To learn more about Portland's native, diverse, and vibrant community, please read Leading with Tradition, a document created by the Portland Indian Leaders Roundtable. And there will be a link to it in the chat. So now I'd like to introduce our sponsor, Amy Viles from Cambia Health Solution. Cambia Health has been a wonderful partner with the OBI for our events and is sponsoring our 2023 Equity in Leadership series. This program today is the second of 4 Lunch and Learns in this series. So Amy, I will hand the microphone over to you, and just please let me know when you'd like me to advance the slides.
Great, thank you. I feel like there should be this virtual mic passing between the different screens. Excited to join all of you today, and Cambia, a prominent theme for us as a company is investing in the community, and as somebody on the digital space, digital health is incredibly exciting to me and my team, and we're really curious about where this is going to go, and conversations like today are incredibly fundamental in helping us to choose the right path. We at Regents, and so Cambia, let's advance to the next screen. So Cambia, many of you may know us in the market as Regents, Blue Cross, Blue Shield. We operate in 4 different states, so Oregon, Washington, Idaho, Utah, and we were founded over 100 years ago. And one of the things that I love about sort of, I guess, my background is Regents was really born out of helping loggers to get access to healthcare, and so sort of a early indication of people banding together to help to improve their health outcomes. So let's advance to the next screen. Again, being part of the community is a huge part of who we are culturally, internally. We also serve a really diverse set of members. And so as we think about how do we create the right environments that can put the right products in the marketplace that help our members, it's really focused on some of these key aspects. It's partnerships, both internally and externally with our community. When we think about best-in-class support, healthcare is complicated, it's complex. One of the things I'm most excited about digital is how we can help to maybe bury some of that complexity in the background and think about simplifying those experiences. Many of the conversations you'll hear today in the Lunch and Learn are going to be helping with that. People have different needs, they come from different aspects of life, they have different life experiences. So how can we think about solving for those compassionately, holistically? And that last part around technology, this is where technology is really critical and could be one of the best enablers. What do we learn about the people that we're helping? How can we use that intelligence to help make the decisions for that next person down the line that much easier? Let's go to the next slide. As we think about it, the company is also, we want to represent the communities that we serve internally as well. So when we think about some of the aspects of DEI, we have strong leadership positions, and we want to make sure there are career paths for women in tech particularly, but also a really diverse set of people. Sometimes you can't always tell by looking at somebody the path that they've walked in life. And so as we think about the conversations that we need to have again, the life experiences that we need to represent. We really look to ensure that we have that represented at all levels within the company. That makes us stronger and helps us to make better decisions. And let's go to the next slide. And this is the final slide. And this doesn't happen by accident. This is about investing in that. It's investing in the people that we work with. It's investing in the communities that are around us. And incredibly proud that Canvia and Regents invests in that community. So we're a nonprofit. We think about the member experience every single day and every single decision. And we also to help providers in the market focus on providing care versus the administration of health care. And so I invite all of you to think about some of these aspects in the conversation today. What does it mean for us to make better decisions? What does it mean for us to understand the circumstances that people walk in their everyday life? And then how do we build communities both in the workplace, but in those around us in our everyday life? So I'll hand it back over and really excited to listen to the conversation today.
Excellent. Thank you so much, Amy. I appreciate it. And now I will introduce our panelists for today. Thank you, everybody, for joining OBI and PDX Women in Tech for this fireside chat. Our first panelist is Cass Wahl, Senior Client Success Manager of Communities at Included Health. Cass Wahl is a Senior Client Success Manager specialized in Included Health's communities, navigation, and advocacy programs. They've been working with large enterprise employer clients at Included Health since January 2021, partnering with health and welfare, benefits, and DEI and ERG teams to remove barriers and make healthcare more accessible to Black and LGBTQ+ employees. Cass is passionate about the work they get to do alongside amazing teammates and clients. They also get to lead Included Health's LGBTQ+ employee resource group and the transgender and gender expansive subgroup, building community and increasing measures of inclusion and belonging. Outside of work, they enjoy Oregon's beautiful scenery, reading, and spending time with their community. And Cass, do you want to say hi?
Hey there. Thank you all so much for joining. Looking forward to the discussion.
Thank you for being with us. Next up, we have Matthew Wetschler, CEO and co-founder of Plume. Matthew is a Stanford-trained physician, entrepreneur, and healthcare innovator, passionate about improving access to healthcare using digital platforms and health technology. As CEO of Plume, he empowers the team to provide world-class trans healthcare and create a more equitable health experience. Matthew, can you say hi?
Hi, everybody. Matthew Wetschler, pronouns he, him, his. Great to meet everyone.
Thank you for being here. Next up, we have Sangha, vascular neurologist at Kaiser Permanente, Los Angeles Medical Center. Navi says, I'm a vascular neurologist, which means that I'm a stroke doctor. It's tremendously rewarding to help people overcome a severely disabling condition and help them live more fruitful and productive lives. I do this by caring for my patients as well as through my clinical research. To maintain my own wellness, I love to work out at the gym and go hiking. However, my favorite way to thrive is to relax in the company of friends and family. Navi, can you say hi?
Hi, everyone. Nice to meet everyone. Looking forward to the discussion.
Thanks so much for being here. And we have Carol Robinson, the CEO and co-founder of Midato Health. Midato Health is a digital health startup focused on giving individuals more agency over how sensitive healthcare and social service data is shared and used. Carol is also founder of Cedar Bridge Group, an established consulting firm specializing in the intersection of health policy and information technology. Before founding Cedar Bridge Group in 2013, Carol served Governor Kulongoski's and Governor Kitzhaber's administrations as Oregon Health Information Technology Coordinator, the administrator of Oregon Health's Authority Office of Health IT, and director of the Health IT Oversight Council. She also served the Kulongoski administration as executive director of the Oregon Health Fund Board, a role where she shepherded passage of ambitious health reform legislation, with the largest Medicaid expansion that any state had accomplished in that point in time in 2009. Hello, Carol.
Hello, thanks for inviting me. I'm excited to be here.
Thank you for being here. And now I want to introduce our moderator, Hazel Valdez. She is the Executive Director of PDX Women in Tech. Prior to her current role, Hazel was the Associate Director for the Oregon Bioscience Incubator and OTRADI, and we loved working with Hazel. Hazel worked with the Executive Director on various initiatives, including working with entrepreneurs and early stage bioscience and digital health organizations on their facility and resource needs, such as equipment, events, funding, etc., as well as OBI's DEI initiatives. Prior to joining the OBI, Hazel was the operations manager at PDXWIT and has been part of the tech community for over 11 years. Hazel studied English at UC Irvine and holds a BA in culinary management from Le Cordon Bleu College of Culinary Arts. Hazel sits on the board of directors as the board secretary for Saturday Academy. In her free time, she loves spending time with her wife, Crystal, traveling, trying out new food items from cooking and boxing as a USA boxing official, and spending time with their cat, Maple. Hello, Hazel.
Hello, everyone.
Well, welcome to all of you, and thank you for being here. Hazel, I'm going to hand the microphone over to you. I'm going to stop sharing the screen so everybody can see you. And Hazel, you have the microphone is yours.
Thank you, Renee. Thank you, Cambia, for sponsoring, and OBI for being the gracious host that you always are. Everyone, thank you for being here today. The topic of equity really does have a far-reaching implications for a better future. With that said, the pandemic has forced healthcare organizations to rethink their digital strategies and develop solutions that facilitate virtual healthcare delivery. Today's discussion focuses on examining digital health through an equity lens. I'm looking forward to this discussion because our panelists are from a variety of healthcare delivery models between them. So let's get started. First question, I'm actually going to start off with Matthew. During the lockdown of the pandemic, how did your organization tackle reaching out to patients using digital health initiatives in underrepresented communities on how to combat COVID-19?
For us, COVID-19, I think, was an opportunity for established telehealth organizations to perhaps leverage the platforms they have. We actually went to market essentially 1 month before COVID, so we were quite immature as an organization at that time. And I think with startups and company building, focus is critical. We did bring education, but we didn't necessarily pivot our platform to testing or really COVID-specific interventions. What we did see, actually, COVID was quite an interesting opportunity for the trans community because it drove work at home, and home is safer than the workspace in many ways. And so what we saw is actually a trend of people taking that leap and becoming and essentially openly identifying as trans. And so we saw it as an interesting moment to provide support to a workforce that I think was willing, because of context, to become more visible to their coworkers and to their employers. I'll pass it to Cass to popcorn. Your thoughts there?
Sure. Yeah. So a little bit of context on Included Health as an organization here to fully kind of answer this question. So Included Health supports care for millions of people across the country as an integrated virtual care and healthcare navigation company. So our members come to us for things like care guidance, advocacy, access to personalized virtual and in-person care for everyday and urgent care, primary care, behavioral health, specialty care, really a whole lot of things. And we work with over 300 employers and health plans across the United States to deliver that care. And that's kind of our access point. We also have a communities specific navigation and advocacy program It's dedicated care concierge service right now for the Black and LGBTQ plus communities. And the goal there is to improve care equity by increasing employees' trust in healthcare, connecting members to high quality affirming care, and then of course things like increasing healthcare literacy and confidence while reducing care avoidance. So with that lens, I will answer this question here. So Included Health took numerous approaches and continues to do so to proactively educate our members and clients around vaccines, vaccine availability, how the virus spreads, how to know if you're safe to return to work for those in office settings, and a lot more through our own virtual care services as well as care navigation services. There was another recent global health concern, mpox, right? And that prompted Included Health to do more, right? To reach out to client organizations, supply information about vaccines, about safe gatherings, testing, treatment. And we leveraged, employee resource groups at our client organizations in particular to ensure that we're reaching the most impacted populations who were dealing with mpox at the time, which I'm sure you all have seen, no longer a global health concern, which is very, very encouraging. But at Included Health, we really give our members a space to be heard and seen, no matter what they come to us for. So given that stigma that many members may feel about seeking help, we're able to get them connected to clinicians that have been rigorously vetted to make sure that they are affirming and knowledgeable about the communities that they're serving. So when there's a crisis that impacts broad or specific populations, we're able to work with and leverage our clinical and marketing functions to develop resources, educational materials, and make sure that we're bringing along both our clients, right, those employers and health plans, and also those members, those end users, those patients, when it comes to actually getting that care. And Carol, I'd love to hear your response here as well.
Well, thank you, Cass. So a couple of things. Midato Health was formed as a new company, a spin out of the consulting firm Cedar Bridge Group in early 2020. So we began developing our platform, ShareApprove, which is a consent management and digital forms platform to make things easier for patients or clients to share their own information with their providers and to give permissions and authorities and basically have agency over how your own data is shared and used by nodes across a connected care network of sorts. And that could include social services agencies, state agencies and programs that you might participate in, and of course, traditional healthcare. At the onset of the pandemic, Cedar Bridge Group was just getting ready to kick off a statewide project in the state of Michigan, where we would normally be on the ground in the field, gathering data across an ecosystem of organizations and consumer types of groups, both traditional and non-traditional types of healthcare, to inform a statewide strategy for health information technology and exchange. And so our normal methods of doing business were immediately stopped, and we had to go back to the drawing board and do what everyone else in this webinar and across the country had to do, across the world had to do, which was learn how to use digital tools differently to engage and inform and collect information, make people comfortable about sharing information in a different kind of setting, where normally one-on-one or small groups would be a great way to get people to open up about some of the challenges they might have. Now we needed to do that in larger groups or without ever having met them before. And so we really did our homework. We studied a lot of types of engagement strategies and tools, and launched that project completely virtual. The example that I'm using also gave us reason to study telehealth and access to the ability to connect to networks in more depth than we had in the past. Now, we all know that rural residents across our country have additional challenges in accessing healthcare and being able to get timely and appropriate care. And so telehealth has been really, booming from the results of a global pandemic. On the other hand, there have been, a number of examples where maybe the go-to-market strategy for some telehealth companies has not been as rigorous in thinking about security and privacy than needed. And that's really where Midato Health and our digital health platform comes in, to ensure that people are informed about how data is being used, shared, collected, why, by whom, for what purpose, for how long. And that's really kind of, I think, the
gist of it.
That'd be all I'll say.
Okay. Navi, I would love your take
Thank
on this and understanding how Kaiser reached out to underrepresented communities during pandemic and lockdown.
Yeah, it's a great question. I mean, it's a very large organization. And so I think I can speak to kind of the nuanced aspect of care that my group helped to provide from the stroke standpoint. I think we actually, in a way, had what we call a COVID positive with the pandemic when it came to actually reaching individuals of underrepresented populations. And one of the examples I'd like to state is that prior to the pandemic, for stroke patients or patients with chronic illnesses, often there are support groups which exist within organizations, outside of organizations, in community settings. And most of the time, well, really, I would say the majority of the time, these support groups tended to be in-person support groups, and individuals from disenfranchised communities or where there was a low-income community, they couldn't make it to those support groups, oftentimes because they did not have transportation, they didn't have awareness, for example, of the support group. And so we realized that we needed to shift our support groups urgently from an in-person platform to a virtual platform. And very interestingly, we were able to actually now have more engagement than we were able to have before in terms of different diverse communities who were joining our support groups. We have several stroke support groups specifically. We also began to discover that not all the communities had the ability to log into a computer, but if they had a phone or a smartphone, then we created the platforms to be phone friendly or smartphone friendly. We also sent flyers to the patients' homes to let them know that, hey, you can join the support groups in any different way, one or the other, in terms of virtual support groups. So if they were able to go to a friend's house safely, that they could join the support group from there. And then we would even walk them through how to join it. So if we would give everyone a 30-minute lead in that they could call us and say, hey, I'm on the computer, but I really don't know how to log in even into my computer. Or someone's helping me on my phone, I'm on my phone, and you guys texted me the link, but now what do I do with this text message? So we actually had groups of individuals just on the phone with these, with our members. And actually, it was even patients, family members who may not have had Kaiser Permanente insurance. Anyone can join the support group. So we were able to really reach the community to a larger degree. And I thought that was kind of more interesting and maybe not necessarily expected when it came to equity. But I think we improved the equity with the pandemic, and we continue to do so now, transitioning back to in-person. We never took away the virtual option, understanding that individuals may not be able to avail that virtual option, but they really felt that what they were getting out of these support groups was quite helpful in terms of how to take care of their family members, take care of themselves if needed, have some respite time, and just to better understand certain disease processes going forward in their own personal health care as well.
Thank you. Great segue into the next question, and I'm going to start it off with Cass. So digital health, primarily known as telemedicine, telehealth, or some form of app that we have on our phone. In your organization at Included, how are you all equitably marketing these products, these healthcare products and resources to consumers while really addressing equity and access to also the underrepresented communities that you serve?
Yeah, happy to kick this one off. So we communicate in a way that is culturally specific to the groups that we support, including the language, the imagery, right? The communication channels that we use with our various populations, such as I mentioned earlier, employee resource groups, really a critical and extremely valuable partner for specifically our employer clients where I work in particular. And then as it comes to kind of the equitable way to access, really related to Navi's previous point, we offer multiple ways to connect with our members for the purposes of care navigation and other things such as phone and digital chat support. For some of our members, they love being able to chat via digital technology, right? And in particular, it's great for people who have things like vocal dysphoria, or whose home lives or kind of home work setup may not really be conducive to taking a call and discussing sensitive health information in the middle of the day. So I can think of a particular example. Large retail employer client with a large LGBTQ plus population that we support on care navigation. We've seen examples of people being thrilled to have the digital technology where they can chat with their care coordinators throughout the day asynchronously, specifically because they're not necessarily able to kind of step away during the workday into a private space. And for others, digital chat is not very accessible. It's not intuitive. It's just not accessible for them. And so they're able to get the exact same support by calling and speaking with care coordinators and providers as well. And although we provide virtual healthcare services, we totally meet members where they are and really believe in the continued importance of brick and mortar care as well. So we can and we often do navigate people to in-person care providers that we have run through quality algorithms and have vetted to be both culturally and clinically appropriate, again, for that member and their individual identities, needs, and goals. Really excited to share on this topic that Included Health recently made headlines for launching the first of its kind health plan for older LGBTQ plus people in the United States. In this way, we provide care navigation and resources to people who experience a variety of gaps in care, as I'm sure you can all imagine. The latest research shows that in the United States, there are roughly 3 million LGBTQ plus adults over age 50, 3 million. And that number is actually expected to grow to around 7 million in 2030. So huge growth in this population. So in addition to the challenges that come with aging as a group, LGBTQ plus older adults encounter distinct health and socioeconomic disparities that, of course, negatively impact their physical and mental well-being. So when you compound that with potentially some of a lack of social and familial support, this really poses a barrier to them aging with dignity. So that's another tangible way the Scan Affirm plan really seeks to support that particular population. And Matthew, I'd love to hear some of your thoughts on this question too.
Thanks, Cass. I appreciate that. Something I didn't mention, just Plume Health, quickly, for those unfamiliar, is a fully virtual clinic for the transgender community, and we are the largest provider of transgender healthcare in the world. So we offer a broad variety of services entirely focused on the trans community, including gender-affirming hormone therapy, which is the foundation of primary care for this community, as well as broader virtual primary care services, mental health support, and community support groups, as well as social and legal support when it comes to gender marker change, navigating, government ID, transition, things like that. So what I would say when we talk about access and equity, I think it's really important to tease out a few things that I believe get conflated. When we speak about access, often this comes to broadband access and digital device access. And I do think it's an important conversation, but it conflates the experience of frontier communities with communities of color or other minority communities, like ones defined by culture and identity. And while broadband access in frontier communities is quite important, it's also one that has strong government funding to continue to resolve it, and it's being driven by multiple sectors because the issues of broadband access affect industries other than healthcare. And so I see that as actually a declining issue. When we talk about digital access for communities of color or minority communities defined by culture and identity, it's much different. You know, the access is an issue even in urban and suburban centers, not necessarily frontier communities. And what you see actually in the pandemic is the greatest utilizers of telehealth were minority communities. BIPOC community was one of the highest utilizers of telehealth in 2022. And the trans community, 80% of the trans community used telehealth to access healthcare in 2022. And so you're actually seeing these communities that we're implying have limited digital access being the predominant users of digital channels during times when the kind of healthcare was pushed into this realm. So just sort of separating that out a bit when we talk about access. When we talk about equity, I think there's two elements of equity: equity of experience and equity of outcomes. And what we know through great public health literature is like some of the canonical pieces on this were Crossing the Quality Chasm into Error is Human, that there's massive disparities in both experience and outcomes for multiple minority communities or even along lines of gender, race, et cetera, that aren't explicable by pre-existing conditions, but purely implies that there is a bias or some disparity of treatment within our healthcare system as it exists now. And it's becoming less and less controversial to say that care needs to be informed by the cultural and lived experience of the communities it serves. And one of the best ways, thank you, Cass, yes, snaps. I'm speaking poetry. Needs to be informed by the cultural and lived experience of the communities it serves. And the best way to do that is to make sure your care team actually has those individuals within it. And what we don't speak about when we talk about digital health is that we all accept this as important, but we don't talk about how to scale it on a brick and mortar chassis. It's extremely difficult. And that, I believe, is one of the powerful contributions of fully virtual care. So for example, we care for, again, 4 times as many trans patients as any other clinic in the United States and more than any other clinic in the world. 80% of our company identifies as transgender. Okay. And that is the power of fully virtual models, that we can actually start to scale care teams that are informed by the lived experience and share the lived experience of the communities that they're serving. And that is something very difficult, if not impossible, to achieve in a physical environment. And I believe what I call it is the supply side and the demand side. Most conversation when we talk about equity, access, et cetera, talks about this demand side. How are we going to get it to, how we make sure digital device access, getting into rural communities, et cetera. And that's half the conversation. The other half is we can scale care teams that are impossible to replicate in a physical environment. And what that does is it starts to inform the care to make sure that people's experiences and outcomes are equitable. And that's kind of the thesis that Plume is built around. From the genesis, every element of our company has centered the trans experience, has employed and brought in trans individuals, and that from there it exudes in our product development, our clinical services, and also just the multiple touch points we have with this community. So with that, I'll pass it to Carol.
Hang on one second. I think Navi had his hand up. So
Navi, yeah.
I'd like, let's go there before we go to Carol. Thank you.
Thanks, Matthew and Cass. And I want to kind of piggyback on what both of you guys were saying. One is to ensure that our communities, our BIPOC, LGBTQ+ communities, are receiving equitable experience and equitable outcomes. And I think without an equity of experience, you can't have an equity of good outcomes, because the poor experience leads to a lack of compliance with healthcare. I, as a gay man, went to a physician and felt that this physician wasn't seeing me or hearing me for who I am and all my needs. And maybe they're telling me all the right things to do, and take my blood pressure medicine and do this. It may not lead to me being compliant with their recommendations because I'm not being seen for who I am. And I think as an organization, we're just realizing this now. And to Cass's point, we're getting older LGBTQ patients now, older transgender patients now, and our elderly patients require more subspecialty care. And we're just discovering as a large organization. Fortunately, we are discovering it. Unfortunately, just discovering it. That we have a lot of great primary care physicians who have put themselves out there as LGBTQ and BIPOC professional leaders, and they're able to provide the care they need to our patients. But what we're realizing is that we don't have the specialists who need to do that, or the specialists haven't identified themselves. Now, are same in the geriatrics realm. And so we just had a large meeting just last Friday with a large group of specialists, and to better understand how we can provide specialty care to our aging populations, or specifically LGBTQ plus populations, actually. And it was eye-opening, really, for myself and to a lot of my colleagues that this was not established before, because we had it already really well established in primary care, but we didn't think about our aging populations and how we need the specialty care. So as an organization, I'm proud to say that we're beginning to move toward that. Sad to say that we didn't think about that until now, and it's just becoming an issue. And actually, it all came into the limelight because of a recent transgender experience where the individual was moving from one service area. We're in Southern California. I'm in Southern California specifically. I know Kaiser's also in Oregon as well, but moving from one area to another area, and they were getting great specialty care from the transgender experience that they were receiving. And then, but they're moving to another area, they couldn't figure out how to identify similar specialists. And it required a lot of telephone, a lot of back and forth, not just from the member, but also from the higher ups to help figure that out. And we realized that this network should be in place already. How is it not in place? It was kind of flabbergasting to ourselves as an organization, really eye-opening. So I think we're excited to move that forward sooner than, I guess, better now than never. But it's just that I think as healthcare professionals, this is something that we should all ensure that we'll be able to do for our patients and know that it's the real issue and that needs to be addressed.
You know, Hazel, I think I'm going to pivot just a little bit from the care delivery to actual clinical research as well, because this is a very relevant, it's relevant to digital health in that there are so many more ways for digital health to help inform research. But, you know, I'm actually old enough and I had my 4 kids young enough where I can remember it was challenging to find a female OBGYN when I was, you know, having my children. And, you know, it wasn't that they weren't any, it was that they were vastly underrepresented. And we know that's flipped in, you know, the 30 plus years since my kids were born. And, but whether you're female, whether you're aging, whether you're trans, whether you're, you know, BIPOC, whether you're dealing with, you know, childhood traumas, whether you're, whatever the conditions or life experiences that you bring to care. Also, we know that clinical research has not previously built in that those algorithms to look at people from where you're coming from, and therefore our drug delivery and our new you know, informed care delivery models have not always been informed by people who look different than, you know, the typical white male. And we've heard some very, very disturbing, we've all probably read them, articles about, you know, assumptions that were made in clinical research. One was that African-American men were less likely to have heart conditions based on certain, factors that had actually been totally put in wrong. Why? They weren't going for appointments as often. So they weren't receiving the care and therefore weren't being flagged as having these conditions. So, I mean, it can be something as basic as that impact, individuals from all aspects of variety that we bring in terms of our care needs and in terms of, how as a medical profession or, I should say medical and social care environment, that new delivery strategies are informed by everyone. And I just loved, Matthew, your examples. They were so inspiring to me. So I'll pass it back to you, Hazel.
Thank you, Carol. Yeah, Navi had touched on clinical research and equity and outcomes as probably, for me, I think of having been in the healthcare industry many moons ago as part of one of the key components of how healthcare delivery should have been distributed out. But it's good that it's come forward and put to light to everyone, and companies like Plume and Included Health are doing that, and even realizations from a hospital entity. Navi, do you have any other thoughts with regards to clinical research and clinical trials and how equity plays into that in creating a healthcare delivery model from a digital health perspective?
Yeah, I think, one of the biggest problems with clinical trials and clinical trial distribution is that most places that provide clinical trial enrollment are large academic centers, and large academic centers are classically not available to the majority of the community. So, I think one of the things that we found with the pandemic when we were enrolling patients in clinical trials was that we were able to leverage telemedicine to now actually bring our clinical trials to our smaller centers throughout Southern California. And we really realized that that's how we were able to increase our enrollment of our different and various communities. For example, there's a hospital that's 30 miles south from us, and they have a larger Black community. And at our hospital, we're a large academic center, and we have a very low population of Black individuals who come and receive their healthcare at our hospital. And we realized that we were not enrolling Black individuals into our clinical trials. So we used that in the pandemic. We put telemedicine carts in the other hospitals, actually, and we began to virtually enroll them and randomize them and give them medications at another hospital. And we realized that this was not only feasible at one hospital, but feasible at multiple hospitals. And we began to target hospitals where we looked at the social economic status of the area to see if we can provide them clinical trial enrollment. And really, to Carol's point, clinical trial enrollment is so important in terms of healthcare that I feel like if you can't provide it at every center every time, then you're denying someone a level of care that another individual might receive. Because when you, as a healthcare professional, when you come to a place where there's uncertainty, but guess what? In Hollywood, if you came to my center, I can help you with that uncertainty by providing you a clinical trial. But because you live 30 miles away in a poor area, I can't provide that for you. How horrible is that, right? And so one of the ways we've been able to bridge that is with telehealth and telemedicine. And I am proud to say that the NIH, at least the National Institutes of Neurological Disorders and Stroke specifically, the subset of the NIH, has created a separate arm just recently, which I'm a part of, to now ensure that telehealth is part of every clinical trial coming out of that organized group, the NINDS specifically, to help bridge some of these gaps where you can actually not just enroll patients in your ivory towers, which are your academic centers, but also where the community actually goes, to the community centers as well. But it's a long road still, Carol, only because people are fearful of change, I think, just in general, and fearful of trying new paradigms of providing clinical trial enrollments. But this is the time, if ever we're going to do it. And I think it's important to bring that change forward to enroll more women, more minorities, and more of our LGBTQ patients as well into our studies, and offer them the benefit of enrollment and not just deny them because they're too far, living in a poorer area, can't access the care. That's a poor excuse and should no longer be valid.
Thank you. All right, folks. I knew we were going to run out of time, and we have a couple more questions. One last question before we can get to a question, I hope, is from all of you, and as founders in respective organizations, how do you think digital health will be used in the next 3 to 5 years? I'm going to start with Matthew, and then Matthew, if you could kick us up, move us along, that'd be wonderful.
Absolutely. I would actually look to government programming to understand the role of telehealth in the landscape. And what you're seeing is there's, research around alternative payment models and delivery models that are happening in Medicaid. And they're seeing a lot of success. And I'd say reason why that's important is because that's where the rubber meets the road as far as being cost conscious and outcomes. Like there's like the highest degree of criticality against models there. And there's an example of essentially a maternal care model that uses virtual delivery that's now getting funded by Medicaid. And so while I think like in investor circles, there's a little bit of a dialogue between the role of virtual health, I think what you're seeing actually is the larger, deeper mechanism of domestic healthcare is now starting to surface and validate the data that this is critical for underserved communities and delivering real value defined by kind of the quintuple aim, and so I would say that the longer element of this is you're going to see greater and greater acceptance of insurance coverage for this, which let's just talk about it. We had to start direct to consumer because it's nimble, it's quick, it doesn't ask permission. And we were able to become the largest clinic that's ever existed on that. Now, we're still only touching like 2% of the trans population, which is significant, but there's a lot to be done. And most of the time, people want to use their insurance, despite the quality, they want to use their insurance to pay for healthcare. And I think there was a question like, what is digital health's role in this 1.5 million Medicaid? Digital health is about outcomes and value. I don't think there's anything about the delivery model that helps or doesn't help. Affordability. Affordability is around insurers being willing to bring these types of solutions in network. And I think that's what we're going to see more of. And that's going to essentially cement digital health as a fundamental pillar of access in healthcare. And I'll pass it to Navi this time.
Yeah, I think honestly, Matthew, you really summed it up quite well. I think it is important for our government entities to continue to ensure that there's reimbursement of new digital platforms. I mean, I think we've grown a lot. The pandemic has helped to grow a lot, but there's also been talk about moving things back to where it was before, because maybe digital health may not be as necessary as before. And I think that would be the wrong way to go. And I think if we're looking to the future, unfortunately, without Medicare reimbursement, it's hard to continue to grow and to provide the care that you need for the patient specifically, because not everyone can self-pay, of course. In fact, we know the majority of our patients cannot, right? And so without the government realizing that this care should be provided, I think we'll fall behind. I think there's a few other things that they can add on to in the future. We have mobile telehealth units that are beginning to be created where you can send a mobile unit to the patient's home. That can't be reimbursed at the moment. In terms of, you can have a mobile stroke unit, you can have a mobile non-emergent unit. And so you can provide that care to that patient's home if they can't make it to you for whatever reason, transportation, perhaps the cost of just getting to you. And all those things are currently unfunded because there's no mechanism for payment. So I think it's really going to be important that our government entities get behind these mobile solutions and telehealth solutions, understanding that the end goal really is that it is in order to ensure the well-being of our community. I'll kick it over to Carol.
So, you know, the conversation has been largely on healthcare, but we know that the health, our health is impacted by our built environment, by our social needs and our history, social histories as well. And so I think that if I look out 5 years from now or so and think about how digital health can help improve the care coordination between traditional healthcare providers and social service organizations that are helping to provide housing services, transportation services, making sure that people have access to, you know, nutritious food and that their social and their social needs and are met, as well as the health needs that may be derivatives of, you know, having to live on the streets or having, you know, housing instability. That's that connection between the two, you know, right now very siloed aspects of services that are provided, all contributing to our health. I think that's the biggest place where digital health can really make a huge difference. So thinking about assessments forms, being able to make sure that your primary care provider anywhere knows whether you have, you know, recently experienced or maybe are about to experience housing instability, or that you may have had a traumatic, you know, domestic violence event that shouldn't be shared without your permission, without your consent, but with your consent and permission, that the proper people know the right information to give you better care. And that's really what I think digital health can help inform.
How about you, Kath? Let's
Yeah,
round it all out here.
happy to. So as I was reflecting on this question, I was reflecting on just so much that I've seen in the market, right? And I think about, like, you know, the future of digital health. It's not an either or scenario, right? It's not about choosing one path and sticking with it. It's about creating infrastructure that works for everyone. So including in the form of culturally intentional and specific spaces, both digitally and physically, in order to bridge some of the gaps that we currently mentioned in health equity in the United States. I think we need to see more research, more training, more technology, more cultural humility, more public-private partnerships, as we mentioned here, to really support the well-being of everyone. We also need to see more providers who are representative of the populations we're serving. We need extremist groups to stop attacking healthcare and human rights. I think digital health will continue to be used to extend the accessibility of care for so many more people. We had a few specific examples of that here. And I think we're going to continue to innovate digital infrastructure that really works to simplify the healthcare system while integrating more closely with brick and mortar care. It is not going to go away. Digital health will be transformational for preventive care and well-being, as well as the treatment of complex conditions and the reduction of health disparities long-term.
All right. Well, folks, we're pretty much coming close to the top of the hour, and some of our panelists have hard stops. They have patients, they have things, and other folks to work with. I want to thank you so much for the insight that you've given us. This conversation can go on 3 different series, because I think digital health is really part of the future in more ways than what I think our government is thinking about it. Hospital care entities are starting to think about it, but folks like Matt and Cass, your organizations, and Carol, being able to use digital health in ways that will really better our future and healthcare delivery models. So thank you very much for being part of this panel. Cambia, Thank you always for being great sponsors to our organizations. And I'm going to kick it over to Renee.
Wow, thank you to our panel. This was an outstanding discussion. As Hazel said, it could go on and on. And thank you to everyone for taking the time to be with us today, especially on a busy news day. I loved seeing the discussions going on in the chat, so that was awesome. And a huge thank you to PDXWIT for collaborating with us, and to Cambia for sponsoring this program and this Equity and Leadership series. The program has been recorded, and the link to the recording will be sent out to all the registrants tomorrow. So thank you all for your support of the Oregon Bioscience Incubator, and I hope you have a great rest of your week. Thank you. Thank you.
Have a wonderful week, everyone. Bye-bye.
Thank you.
Bye. Good job, everybody.
Thank you.